wonderful discussion on a routine day-to-day topic. Now we move on to the hematology session. Our chairperson is Rangaraju. May I request you to please give your introductory comments first.
Good morning, everyone. I think nice to see the good crowd in the early morning and Sunday. So now we'll be deviating from the solid tumors, going on to the liquid tumors, both myeloma and the CLL. And the two very important papers of practical relevance are being discussed. And one of them is the myeloma, where second-line Daratumumab has been used. And then that's what is the PERSEUS trial. And then the other one is the CLL. When we treat them, they do have a residual disease. How to manage them based on the residual disease, I think that's something which we've learned from ALL and many other situations. So we'll see how these discussions are going. So may I request the moderator and the panelists can have the names? Yes. Dr. Ashish Bakshi, over to you.
So, very good morning. We have 45 minutes, right? Okay. So, the first, I'm going to present two studies. The first one is in relation to myeloma. This is the PERSEUS trial, which is Daratumumab, Bortezomib, Linezolid, and Dexamethasone for multiple myeloma. Now, standard treatment for myeloma as of now involves giving VRD as induction, typically 4 cycles, then autologous transplant, followed by VRD as consolidation, and then give lenalidomide as maintenance. Now, phase 3 trials have shown improvement in median PFS and improvement in CR rates with this strategy, and this is the current standard of care. A phase 2 trial called Griffin actually added Daratumumab to the VRD induction, and this was a phase 2 randomized trial where similarly 4 cycles of induction with Dara VRD were compared with VRD 4 cycles, autologous transplant, and then consolidation. Again the patient received Dara VRD, and then maintenance was with Dara and lenalidomide. Now, Daratumumab is approved, as we know, for both patients who are eligible for transplantation and ineligible for transplantation. Now, coming to the main trial, this PERSEUS was an open-label randomized phase 3 trial. Median follow-up is of 47 months. Similar to Griffin trial, what I just described, the patients received 4 cycles of Dara with VRD, and they were compared with VRD, and then autologous transplant was done. Patients again received consolidation. The arm with Daratumumab received Daratumumab in consolidation also for 2 cycles, and then the patients were given maintenance with Daratumumab and lenalidomide. All patients were given Daratumumab and lenalidomide for 2 years, and those patients who were MRD positive at the end of this period, they were continued on Daratumumab and lenalidomide till progression. And those patients who were MRD negative, they were just continued on lenalidomide maintenance till progression, and Daratumumab was discontinued at that point of time. So this is in short the PERSEUS trial. Now they assessed MRD in this trial with the help of NGS with the clonos assay, and the target was MRD up to 10⁻⁻⁵. On an exploratory basis, they also looked at 10⁻⁶. These are the patient characteristics between the two arms. They are quite comparable. Very few stage 3 patients are there. As you can see, just about 15% of the patients in each arm are stage 3, and most of the patients are standard risk, which means that 75% of the patients are standard risk myeloma. High risk myeloma is just about 20%. Now, important thing to note here, and which is a little bit surprising and which we will come to in discussion, is that the adverse events, discontinuation due to adverse events was slightly more in the VRD arm, 22.5 as against just 9.1 with the Dara VRD arm. Similarly, the number of patients who entered maintenance was slightly less in the VRD arm, 91.7 versus 86.5. The number of CD34 cells collected was slightly less in the Dara VRD arm, 5.5 versus with the VRD arm of 7.4. Otherwise, patients underwent transplant, almost equally number of patients underwent transplant in each arm, and the median time to engraftment was also identical in the two arms. In terms of progression-free survival, what this trial showed that the addition of Daratumumab to the VRD regimen led to an improvement in progression-free survival of 84.3 versus 67.7 with the VRD regimen. So there is definitely a significant improvement in terms of the progression-free survival. Patients who are more than 65 years, there was not that much benefit of DARA, but very few number of patients. Similarly, the benefit of the DARA VRD regimen was more in standard risk as compared to the high risk. High risk didn't seem to benefit as much. They did benefit, but not as much as the standard risk. Now, in terms of the CR rates, 87%, stringent CR rate 69 versus 44.6. So, improvement in CR rate, MRD negativity 75.2 versus 47.5. So, both 10:5 and 10:6, there is a significant improvement in the MRD negativity with the addition of Daratumumab. These are the MRD PFS plots. However, as of now, there is no improvement in survival. Both the, as you can see here, the curves are overlapping. In terms of the side effects of this regimen, as expected, the hematological toxicities are more with the addition of Daratumumab. So, neutropenia, thrombocytopenia, incidence of infections is slightly more in the group of patients that received Daratumumab as compared to those without. So, these are the conclusions of the investigator that the addition of Daratumumab leads to improvements in PFS rates, improvements in CR rates, improved MRD negativity. So, everything looks very good when it comes to this, but there is no overall survival benefit yet. So, let's move on to the discussion first with this trial, and then we'll go on to the CLL trial. So, here important thing to note is that in the PERSEUS trial, Bortezomib was given twice a week, and which we all know that is known to cause more peripheral sensory neuropathy. However, in the adverse effect profile, you don't really see that reflected actually. They have not really seen that much neuropathy. One more thing that when you are reading the fine print, this is from the NEJM article. The results for the forest plots that they have given, the results of these outcomes are reported as point estimates and 95 confidence intervals. However, the width of the confidence intervals have not been adjusted for multiplicity and cannot be used to infer definitive treatment effects. So we have to be very careful in interpreting the data as has been published. Now coming to the comments from the panelists, how can we really explain that with the VRD the AEs are more as compared to DARA VRD?
So in addition to coming to this, there are a few things which I think needs to be highlighted about this study. The first is that they use subcute Daratumumab in this study, and
Yes.
the infusion-related toxicities were only 5 or 6%. So that is a huge plus. If you are adding a new agent, and we are all aware that if you use IV Dara, then the infusion-related toxicities and sometimes grade 3, grade 4 can be as high as 30 to 40%. So this is at least the infusion-related toxicities are very manageable. And the second important thing which I think Ashish highlighted for me was that I think all of us have now shifted to weekly Bortezomib. And the steroids given in this study was again not like what we usually practice, 40 milligrams once a week.
4 days and
It was a
like,
lot more complicated and difficult to give and logistically difficult for the patient. One more issue for me, at least on this study, was that once the patient completed the consolidation cycle, then they went on to receive 2 years of both DARA as well as LEN. And this is like a addition of a subcute agent and an extremely expensive agent. If there was a randomization here, say for example, patients who were MRD negative right after consolidation, they would receive only LEN. That would have been better if you could have saved on some cost because of the DARA.
Yeah, Amish.
And this issue, also hit me in the face when I was going through this article. And it hardly ever happens that when you use 4 drugs and compare that with 3 drugs, the 3 drugs being same, you have less toxicity. So this is difficult to explain. The only explanation which I have is that maybe the improvement in the quality of life of the patients was such that they were able to tolerate the regime more if you have a PS 1, 2, and if you have a PS of 0 to 1, then obviously you tolerate the toxicities better. So
Yeah,
that
Amish.
is the only explanation I have.
Can you go back to one slide? I think discontinuation is something which depends on the primary principal investigator in discussion with the patient. If you see the SAE and the death, they are not different. SAE in fact is 57 versus 49%. So the 4 drug has more SAEs compared to 3 drug, which is understandable. That is one. Second, death is also no different per se. So I think what principal investigator took the decision along with the patient is something a subjective thing. But objectively, I don't see any major discrepancy in the side effect. Before we answer, my biggest...
So that is the surprising part, that when you read at the toxicity profile, you are difficult to, it is very difficult to understand that why was
True.
the drug really discontinued.
But before we go back to the next one, PERSEUS trial, does it hold true? If my patient can afford all DVRD, I want to give because of all the results, but the patient is not eligible for transplant or refuses for transplant, then can we apply this data in our day-to-day practice? Is a question ever since I read PERSEUS trial is, haunting me.
No, one thing, Dr. Amish, the physician decision is a different subset altogether. What discontinuation, what is speaking is due to adverse event, and that is pre-specified in any protocol. See this.
See here also, if you see,
The physician decision is different, and 4 numbers. That is different. Expected, no? Expected that the standard arm will have more progressive, but the first one is unexpected. I totally agree. No.
So anyway, let's move on. We have to discuss a lot of other important issues also with this trial.
We cannot explain that.
Yes. So, so now the question is that, is the PFS benefit good enough for all of you to start using Daratumumab for everyone, or you will wait for more mature OS data?
I will wait for OS data, definitely.
Okay. And
The previous the phase 2 data that you showed
Griffin, yeah.
already have a taste of events to come. Definitely, we have seen that Dara is such a powerful drug in much treated patients. So, as logic with anything, as we heard earlier, the why not the best batsman up front? You heard it often today. So, therefore, the logic is, why not bring the drugs best first? It's not only the PFS, you also see the CR rates, and then more importantly, you see the MRD negativity. If you look at the way the myeloma has evolved over a period of time, why do transplant at all in the first setting is because everybody knows that even after transplant, there is a possibility of, it's always a question of how to deepen the PR. That has been the endeavor from ever. So if only we can clearly show that the MRD negativity rate can be much better, that makes a logical, biological sense for us. One of my own student, a third year student this year, his thesis is that MRD negativity or MRD rates post first line induction 4 cycles. So we are also doing 10 to the power of -5. And I think this June he will present the data. It could be 4 drug or 3 drugs. So we are doing that. So I am very impressed with the MRD be down. So that makes sense in the biological sense. Actually. One question to you: was the Bortezomib subcut or not in this one? Both the arms. Dara is subcut. But
I think Bortezomib was also subcut. Yeah.
But it was twice a week.
Twice a week.
Yeah.
Yeah, Dinesh.
I think when you were asking, Dr. Amish was asking whether patient, it will be applied to the non-transplant. So for non-transplant, we have another trial with the Dara, Len, Dex. So rather than going for 4 drugs, you have an effective 3 drug combination. Someone who is in between, you can use a 4 drugs, but someone who is frail or the older side,
and
transplant
ineligible would primarily mean that tolerability to 4 drugs would be difficult.
Slightly.
Right?
The other important thing is this is for the transplant patient. So we have to translate to our country. So transplant is important. Someone should not spend money on Dara and then don't get a transplant done. So someone has a money for Dara plus transplant, that's a good option. High risk, this didn't show any outcome difference, but you will end up using a 4 drug. So the high risk, I would definitely use a Dara VRD, someone who can afford it and go, and then he has to have a transplant because he's a high risk. Standard risk, we will discuss it, but we don't have a data. After the first relapse, you should definitely use a Dara. Rather than using it at the 7th relapse, use it at the first relapse. So transplant is important. High risk, I would use it for Dara VRD. First relapse, I will insist if you can afford it, use it now rather than using it at the 7th relapse.
So we have been using 4 drug induction for some time now. My question is, we have been so far using the IV and IRR is there. Can the available formulation in India can be used subcut Dara? So
No.
Clarify.
No, the Dara subcut is available now.
It's
So there are two
available now.
different things.
Two different things. That's going to be launched or it's already
Has been launched.
Launched.
Has been launched. So we need to see the finances of the whether the which one is cheaper.
It's pretty close. The costings is the same, and it's like Fesco. No, it has 10 ml of hyaluronidase so that it makes a subcute pocket, and then it's absorbed from there.
Can you go back to your first question? If I don't remember a single this thing, lenalidomide maintenance we are using for 2 years or till progressive, very commonly in myeloma. We don't have an OS data.
So that is the surprising part, Amish, that why so many patients in the lenalidomide maintenance arm dropped out. And
No.
whether that will impact
You were talking
have
of PFS or you should wait for OS, and sir said I will wait for OS data. What I'm saying is, len maintenance we are giving in almost all myeloma patients. There is no OS data based on my knowledge. It's only PFS data. Forte trial which confirmed that cyclophosphamide should no longer be used, that is a European data, against PFS data. Multiple myeloma, I think if we wait for OS, we are going to miss out lot of early good drug. That is what how I would look at it.
correct. So we'll come to that. Dr. Dinesh.
One more point I wanted to say, that there is a CAPSIA trial. If you are used upfront Dara, then there is no advantage of using into the maintenance. Means there is some data, they have 4 arms. Someone
So
had
we'll
used the Dara
come to
into
Cassiopeia.
Dara.
I have the slides.
So can you show that slide? So
I
it's
will
not
just
necessary you need to have a Dara in the maintenance if you have used upfront. And if you have not used upfront, you can use it in the maintenance. The outcome is similar.
Yeah, I think that is one of my objections to this study, that they didn't address that question whether Dara is needed post consolidation or only len is enough. They did not address this. So
that is after 2 years.
But everybody got
everyone
2
received
drug
it.
maintenance for 2 years.
So actually, how many of you will give importance to MRD negativity? Dr. Raja, you said that it is very important parameter, and to answer the question about OS, Amish, actually this large meta-analysis has shown good correlation between MRD negativity and OS benefit. So it's a good surrogate marker for long-term OS benefit.
Just to point out, Ashish, that in none of the guidelines as of date, it might change this year, MRD is recommended as standard of care in myeloma assessment and treatment decisions as of just now. We are expecting it to change this year, but it hasn't happened till now. Right, Dinesh?
And for this OS thing, actually, we don't have really a good data on whether we should wait and all that. But when they've done a statistical analysis, actually, when you give Daratumumab as upfront, as you can see from this, if you give Daratumumab as upfront, the survivals are about OS at 7 years is 7.6% with Dara already in first line, followed by pomalidomide or carfilzomib as second line. If you use Dara as second line, it is 5.1, and if you use Dara in second line with RDS first line, it is 4.1. So there is some kind of indication that probably using it as first line makes more sense. Similarly, time to disease progression and time to next line therapy is more if you use it as a first line. Now, coming to what Dr. Dinesh sir had raised this pertinent question, is maintenance therapy given in PERSEUS is really required? Now this Cassiopeia trial, I'll just briefly explain the design. This was a 2-stage trial actually. In the first part, they compared patients who were given VTD 4 cycles and they were randomized to Dara VTD. So VTD versus Dara VTD. Patients underwent stem cell mobilization, VTD for 2 cycles, and the other arm received, the Dara arm received again 2 cycles of Dara VTD. This first comparison, it showed that there was a PFS benefit with the addition of Daratumumab in induction. The second randomization in the Cassiopeia part 2, it's called as, where actually the patients were randomized to observation versus giving Dara every 8 weeks. Again, this is important point, Dara every 8 weeks. The observation arm just received lenalidomide. So what this showed is that if you look at the forest plot, the patients, those who received Dara VTD as induction, there was no benefit of giving maintenance in this group. Those patients that received VTD as induction, there was a benefit of giving Daratumumab as maintenance. Now, based on this, again, these are the sort of PFS curves, no significant benefit between Dara VTD followed by Dara versus Dara VTD versus observation. The hazard ratio is 1. So I think this raises a very important point that for our patients, what should we be doing? Really we follow the PERSEUS data that has been presented, because from a cost-effective perspective, actually giving Dara in induction, you give limited number of cycles and then follow up with observation as against giving all throughout in the PERSEUS trial.
This is only PFS, isn't it? We are not looking at what salvaged the VRD patient or the 3-drug patients when they relapsed. That's not.
So here also there is no OS benefit as yet.
Yeah.
So
why I'm asking is that most of them are probably in their country setting are going to be salvaged with the with Dara based therapy at some point. So what happens? Then one other thing is that in patients who have been pre-treated with Daratumumab, and after some time, if there is a gap, you can rescue them once again. So I think the maintenance probably doesn't make sense. That's what I think.
Ashish, in PERSEUS trial, is there a time-based MRD increment? Because I couldn't, like in CLL, we will discuss. Is there that, if you keep giving Dara maintenance, say MRD, I think 75% patients achieved MRD negative status in DVRD arm. But is it increasing as per the time? No.
So this, to answer your question, Amish, this master trial, actually they have shown that what you are saying, this is a phase 2 trial. They have done actually MRD assessment at periodic interval, and they have shown that the duration of Dara can be modified based on the MRD negativity, but this is a phase 2 trial. So the question is that, is it practical to use this regimen in Indian patients? How many of our patients would be really be able to receive this regimen?
I think the first consideration would be the cost. If we keep cost out of consideration, the ground reality in our country is quite different from what was shown in this particular trial. I think 2/3 of the patients were in stage 1, and the median time of onset of myeloma to start of treatment was 1 month. So we never, face that kind of situation. Our patients are a lot more, our tumor load is a lot more than what they see in the West. And the second thing which struck me was that most of the centers in India are doing MRD assessment by flow, if they are doing MRD assessment. Very few centers, including academic centers, are using the clonoSEQ and the NGS platform to do the MRD. So that again, it might be a difference in assessment of the MRD. I think MRD is important in myeloma, there's no question about that. And possibly an expensive maintenance in our country should be MRD based rather than for everybody. Those are my thoughts.
Yes, Tarini.
There are two things I understand from it. Again, I don't practice a lot of the transplant myelomas. The one first point is the trial which you showed, the maintenance of the Dara versus Len. That trial would show you the Cassiopeia.
Yeah.
So that did show that you would need a maintenance, and either of the drug, if given, were equivalent in the maintenance. What the trial which we are discussing is showing that the maintenance, as I get it, 2 years of a dual maintenance versus a single. I do not. You have to actually look at that way. What they have looked at this trial is a dual maintenance versus single maintenance, and the PFS is superior for the dual maintenance. So I think we are taking this trial as per the convenience. So we are there's a two different questions.
So obviously you can't do a cross trial comparison between Cassiopeia and Perseus because
if this PFS also would not have shown a difference, then that point of post-transplant maintenance would have come in question. Here it does make a significant statement that a dual drug on the PFS is superior to a single drug. I think these two trials are asking two different questions. Number two, if someone has to accept this trial, in Indian scenario, we have to then take the protocol as it is, and then only you will get the desired result. Otherwise, I don't think then the Cassiopeia trial will be the only one which we will be practicing. But this trial is looking at very different things than what the other trial is.
So anyway, that question between Cassiopeia versus Perseus will have to be answered by a completely another trial, actually comparing the two approaches.
But the PFS is so significant, though it makes the statement
but
that...
PFS is better in both the trials in the sense that...
But here the maintenance, the comparator arm is the single agent lenalidomide maintenance.
Yes.
So the first component would have played a role, but also maintenance would have also played a role.
So TP, there is like published data and also recommendations that if you have a high risk myeloma, then 2-drug maintenance, and the 2-drug being Bortezomib and lenalidomide is better than only lenalidomide. There is data and recommendations to that effect also.
My one last,
but whether you use Dara or Bortezomib.
No, high risk myeloma, people recommend, like, loss of chromosome 1 is a very, very high risk cytogenetic abnormality in multiple myeloma. There is a lot of data about the dual maintenance compared to the single drug maintenance. But the point what Dr. Hemant Malhotra sir said, the staging of myeloma, I think that 3.5 M protein cutoff is a lot of now changes, sir, in the patient scenario. You have a lot of free light chain assay going up, beta 2 microglobulin. So I think that old staging probably is not the real representation of this. Now, this is something what we see in high-risk myeloma. Rather than stage, I am seeing more of high-risk myeloma rather than the staging of myeloma.
So, actually, with regards to the high risk, again, this is one thing that when we look at the meta-analysis of Cassiopeia and Griffin, the benefit is more with standard risk. The benefit with high risk is actually less with the addition of Daratumumab. It's not as good when it comes to high risk as compared to standard risk myeloma. We will add, of course we will add, but that is something.
If you see very high risk myeloma, Ashish, hardly anything is working so well as compared to other drugs.
Correct, but this is something important to remember.
And then, you have the KRD regime for high risk, which has shown benefit.
One more point we raised. How do you feel about the carfilzomib based 3-drug regimen compared to the Bortezomib?
So that is the KRD which I just said.
Unfortunately, there was a one trial KRD versus VRD which failed, and there was only one group of high risk was involved, and the whole lot was not involved. The 414 was there, the rest of the things were not there. But I think the KRD, there's no data, but I think KRD should be better. I mean, if you're not using DARA, either use a DARA VRD or use a KRD. Using a DARA KRD is more toxic. So you need to be careful.
So I think, Tarini, I will have to cut you because we are short of time and we have to discuss another trial also.
Come in is the ISKIA trial. And that trial will have this. And there you see the benefit of adding an antibody to a CD38 is getting shrunken. If you're using the carfilzomib arm.
Ashish, is there a takeaway from the trial? At least we should see whether this is going to be worth for any particular profile of patients. As of now, based on the phase 2, the high risk is where we were using the 4-drug regimen. So whether there is a takeaway from here to do something or not, what will the panel want here?
Right. Okay, I think we'll move on. Can I have the second presentation now?
So, while you are moving, what is the consensus? Is this practice-changing paper, DARA VRD? I think that is what I would like to, in both, in the concluding remarks, Ashish, you had put in a nice table. So, in a standard risk myeloma, you had said that based on PERSEUS trial, DVRD can be given. But in a standard risk, transplant can be omitted. Is that the understanding what I take? I would like to ask, because that the table which you had put that.
Transplant is not to be omitted.
No, standard risk, you said that if MRD negative and no
So
high risk
you can
features.
discuss with the patient upfront trial versus a delayed transplant, but transplant is not
Is
out.
not.
Yeah. So okay, let's move on to the next study. Again, an important study, CLL therapy guided by MRD. Lot of issues are there in CLL with regards to the number of drugs to be given, what drugs, what should be the duration of therapy, fixed duration therapy or a time limited therapy or intermediate therapy, and individualize the patient. And a lot of trials have been done actually. This specifically I put it because it's a very complex, when you try to read the data, so many trials comparing one with other, it's really very confusing. So this FLAIR trial is a platform trial like the Stampede trial. The first part trial compared FCR with IR, which showed that improvement in PFS with ibrutinib rituximab. The second part of this trial is what we are going to discuss today, the comparison of FCR with ibrutinib and venetoclax. So this is the design of the trial. Patients were randomized to FCR versus ibrutinib and venetoclax. Initially, ibrutinib was started to take care, and then once the risk of tumor lysis was less, venetoclax was added with the ramp up schedule. In this they have not discussed the ibrutinib one. Yes. So they are not compared in this the ibrutinib one. So the inclusion criteria were previously untreated CLL or SLL, and exclusion criteria were Richter's transformations and CNS involvement, and any patient who had more than 20% of CLL with chromosome 17p deletion by FISH, they were also excluded. Now this is important to understand the design of the trial. Actually what they did was that patients MRD assessments were done at periodical intervals. So say for example at 1 year they did the MRD, sustained undetectable MRD to confirm stopping was rechecked with the peripheral blood test after 3 months following the first instance where the undetectable MRD was noted, and it was confirmed with a bone marrow aspirate and peripheral blood test 6 months later on. And the duration of therapy was basically governed by the stopping rules. So say for example if somebody had an undetectable MRD at 1 year, they were given the drug for 2 years. Somebody had for 18 months, they were given for 36 months, like that. So the duration was exactly the double the time required to achieve the undetectable MRD. If MRD relapse was noted on follow-up while following the patients, then they were treated for a complete duration of 6 years. So this was the maximum period for which most of the patients were treated. The primary endpoint of this study was progression-free survival. In terms of patient characteristics, most of the patients had progressive A or B from BNET and very few upfront progressive BNET C were there. Now, if you look at the genetic mutated IGHV mutated status was about in 35%, also 1/3 of the patients were roughly IGHV mutated. There was some imbalance in the two arms with regards to the IGHV mutated. Then TP50 deletion patients were excluded. ATM deletion was there in about 17 to 18% of these patients. Now 6 cycles of FCR regimen was they were able to give in about 66% of the patients. So 2/3 only could receive actually the complete 6 cycles. The median number of cycles of ibrutinib was 27. So roughly about 2 years of ibrutinib for everyone, 2 years of venetoclax for everyone on an average. Dose modification, reductions and delays and omissions, 55 versus 55, almost comparable dose modifications in the chemotherapy as well as the ibrutinib venetoclax arm, which means that the drug combination is not really easy to administer also. Again, coming to the results of this trial, at 2 years about 29% of the patients could stop the ibrutinib and venetoclax. At 3 years about 60% could stop it. At 5 years about 80% could stop the combination. So almost up to 5 years 80% could stop. So that means, but a lot of patients required longer duration of therapy also. Now coming to the results, if you look at the CR rates with the IV venetoclax ibrutinib combination, CR rates are 59 versus 49. MRD in the bone marrow 65.9 versus 49.8. PFS again 97 versus 76.8. So all these factors are significantly better. As of now, though, there is no difference in the overall survival, 98 versus 93. So there is a 5% difference, but which is not statistically significant. As expected, the toxicity was slightly more with cardiac toxicity was slightly more with ibrutinib and venetoclax. So 10% versus 0.4%. Hypertension, atrial fibrillation, arrhythmia, cardiac SAE were more with the ibrutinib venetoclax combination. Hematological toxicity in terms of like infusion reactions or febrile neutropenia was hardly there with ibrutinib venetoclax. Neutropenia, thrombocytopenia, anemia was definitely more with the FCR regimen. Important thing to note here is that GCSF use 21.5 in ibrutinib venetoclax and FCR 56.7. So patients with the ibrutinib and venetoclax arm also sometimes required GCSF. Coming to the PFS and OS curves, definitely significant improvement in the median progression-free survival with ibrutinib and venetoclax. Patients with unmutated IGHV, again significant benefit in the PFS with the combination as compared to the chemoimmunotherapy. In the mutated arm, there is no difference. Whether it is the PFS or OS, IGHV mutated, there is no difference between the two arms. Here again, the OS, there is a separation of curves, but there is no significant, statistically significant benefit in terms of the overall survival yet. Now, the conclusion of the author is that MRD guided ibrutinib venetoclax was superior to FCR with respect to the progression-free survival. So, 97.2 versus 76.8 at 3 years. Results of OS also favored, as I said, 98 versus 93, but not statistically significant. So, these results, they appear better than ibrutinib monotherapy, venetoclax monotherapy, or a combination of venetoclax with obinutuzumab. The MRD-driven approach in FLAIR trial led to the 30% of the patients stopping the drug by 2 years and 60% stopping the drug by 3 years. So, using MRD to define the duration of ibrutinib venetoclax treatment may result in improved outcomes and allows for individualization of therapy. Now, these are the author's conclusion. Let's now come to the discussion part of it. Same like the previous trial, I have not read this kind of a clause in the previous publications, but surprisingly here also they have said that the p-values, the confidence interval should not be used in place of hypothesis testing or to infer definitive treatment effect. So I don't know like how to read this. Now coming to the question, is there any patient today based on these results and other trials that are published? Is there a patient today whom would you recommend, Hemant sir?
Before that,
So I think
to
till
that back slide, can you go to, does it just not mean that the p-value for testo heterogeneity is insignificant? So do not read too much into subgroups.
Yes, so
I think this is a standard thing. Yeah. So if it is that what they're telling, because we are looking too much into subgroups nowadays, so they're telling don't do it.
But they have,
Huh? Yeah.
yes, but we always tend to look at the forest plot.
No,
That's
don't,
the reason.
You should not. They're telling
Okay.
So I think till venetoclax becomes freely available, we will still have a significant number of patients who would receive. I mean, I don't use FCR only other than a very young fit patient. We would still be using these regimes till venetoclax becomes freely available. I don't use the Bangladesh version, and the US version is very, very expensive and difficult to procure. So as of just now, for at least a few more years, we are still stuck with the IV chemo. Shifting more and more to Bruton tyrosine kinase inhibitors and anti-CD20s, but still a significant number of patients do receive the chemoimmunotherapy.
Dr. Ashish, it makes a lot of sense in a chronic disease like CLL to be really driving the disease based on MRD negativity. It makes absolute sense. I want to ask you whether you had any more information on the combo of ibrutinib plus venetoclax when the dose modification was needed. Which drug did they modify most? Was it the venetoclax? Because in general, we have been using ibrutinib quite well for some time, and the chronic tolerance even in elderly patients are very, very good. And particularly if there is a cardiac issue, acalabrutinib is now the drug of choice. We use that. Whereas venetoclax, even in the current indications and settings, 400 is it's not routinely. We really bring it down to 200. Dinesh can. So I just want to know.
So I think in the supplement, if you read, they have given that, and both the drugs required modification. So maybe I think it's some 30% or so, but both of them
If you have a bleeding or hypertension, they would have reduced ibrutinib, and if you have a cytopenias, you would have reduced it.
One of the, I think, the
Do you do MRD in the marrow and blood, or only in the marrow?
Start. Yes. Then you start doing marrow.
At 3 months.
No, peripheral blood once, peripheral blood second, and then bone marrow in the 6 months.
They do it for peripheral blood 12th month and then 6 monthly. Once you achieve MRD on the peripheral, then they do it on bone marrow and peripheral blood for 3 monthly. 2 times. That's what.
Yeah, Dr. Dinesh, what is your take on?
The first one, we are not using BR anymore. Means probably there may be some patient differences. Acalabrutinib is available, so ibrutinib is out. Acalabrutinib is cheaper, is available. So continuous acalabrutinib is very well tolerated and accepted by the patient. So acceptance is much more with the acalabrutinib. It's just we have to monitor for the cardiac risk. So probably BR we will give it someone has a high risk of cardiac and hypertension. Otherwise, it has become like a more of a CML.
Amish, तू ज़्यादा time देने वाला है क्या?
नहीं, this is exactly what I wanted to say. Even somebody who does not have a cardiac comorbidity. Let's talk of this paper, ibrutinib combination with venetoclax. There is a 10% cardiac, in spite of MRD associated modification of the drug. Let's not forget 10% is a very high in a disease where 3 years, 5 years, 7 years, you see all the papers more than 90% overall survival at the end of 3 years and 5 years. How can we justify cardiac toxicity in 10% of patients in a chronic disease is my question. I would ask myself twice.
So that's the next point. This is a philosophical question, that are we really over-treating the patient? Now this data you see, this is from the CLL 12 trial comparing ibrutinib versus wait and watch. You see event-free survival benefit, progression-free survival benefit, time to next treatment with ibrutinib. But there is no difference in overall survival, and we do not really use for patients who are asymptomatic.
So Ashish, the inclusion criteria in the study was patients of CLL who required treatment. It was not asymptomatic patients. There is a 5 or 6 set of criteria.
No, all the patients fulfill those. So, but the question is that when we are comparing wait and watch versus ibrutinib for patients who are not having any symptom, there is still a difference. But there is no overall survival difference. That is primarily the reason we are not actually offering ibrutinib.
BR followed by R maintenance.
So are we really over treating patients? These patients.
Should we not look into one more trial published in NEJM 1 year back, which is a triplet of ibrutinib, venetoclax, and the OBTO?
Yeah, that is the CLL 13 trial that you are talking about.
And what I mean to say is the 15-month MRD is a 93%, which is equaling the same as you're seeing with this trial. And the point which I want to make is there you're giving it for 12 to 15 cycles. How much will be the cost in India? No, here it will be it is a larger cost because it's going for 6 years, and there it is the 12 to 15 cycles. So my point was that we have equivalent MRD trial. So should we not be comparing this with that trial? Is the question I'm asking.
I think that is a relevant question in our country because venetoclax is not available to us. If you have an oral regime,
this is what the question is, that you are saying, that should you follow a fixed duration approach or a MRD driven approach?
So what is the real benefit? Is there a data to say either acalabrutinib single plus doublet? Is there a difference in the MRD, or is there a data available to say that?
With acalabrutinib versus acalabrutinib with obinutuzumab, yes, it is there. But again,
venetoclax,
no,
there is no.
There is no. I think that trial is coming.
So with that fixed approach, you are getting the same MRD results. That's what I meant.
So here, that is what the authors are trying to say, that in the GLOW trial where it was just given for 12 months in all patients, 54% had undetectable MRD. Okay. In FLAIR trial with continued therapy based on MRD, 92.7 actually had MRD negativity. So that is what their point is, that it should be adapted to the patient. So anyways, this is something that is controversial. Now we are using venetoclax at 100 milligram along with voriconazole. So my question to the panelists is that in your practice, would you use this? Yes. So I think most of our patients would. All right. So MRD is something that has been controversial. Now this is a title from 2013 April. MRD, is it ready for prime time? And this is from this year's ASH. MRD directed therapy in CLL ready for prime time. So we are still questioning actually even after 10 years that whether really one should treat the patients based on MRD. So lot of drugs have been shown to have an excellent improvement in the bone peripheral blood as well as the bone marrow MRD. But that is the question, that is really achievement of MRD essential. Again, if you look at the ECOG 1912 data, with ibrutinib monotherapy, only less than 5% of the patients had MRD negativity. But with in terms of the progression-free survival, actually there is hardly any difference. So really the question is that whether one should decide. There are a lot of technical aspects also with regards to with the MRD in terms of what should be the detection method, which should be the compartment that you should look at. These are the controversies that have been raised, and some of the points have been addressed in the consensus guidelines for MRD by the CLL group. Now, this statement that I have put up here is actually from that consensus guideline on MRD. It reads as testing of MRD in peripheral blood at the end of treatment where flow cytometry can provide valuable information, but should not be used to modify treatment outside of clinical trial. Likewise, serial MRD assessment currently do not have clinical implications. So the question to the panelist is that with the publication of this study, do you think that we are ready to change?
Not yet. Only one question. Do any of you use it as a stoppage criteria? If the patient has good tolerance, in patients who are doing well, if MRD is consistently negative, if the tolerance is good, do you already use it as a stoppage criteria?
They are showing it. If you are MRD negative, you can stop it. So
I'm asking in real practice today.
We
so
don't
would
have
you
venetoclax, and with the acalabrutinib you don't get MRD negativity, so we don't stop.
So practically speaking, for us, MRD monitoring doesn't really help us at this point of time.
So for a mutated one,
Started doing it, Ashish. Let's put it that way. Once we embrace this trial in the patient who is symptomatic, high risk and requires continuous treatment, I think once we start adopting, probably it will come. See, the most important point, as you pointed out, the last point in this trial is 47% going into more than 95% MRD negative, while the continuous. If MRD makes a difference in your clinical practice in CLL patient and not over treatment, as you said, then I think it is very important that we adopt to this in select patients.
So Tarini, you raised this issue.
Do anyone know when venetoclax will be routinely available in India? When are they going to launch? And
two more years.
So Ashish, for the mutated, it is still FCR. That's a take home. Nothing beats
for
FCR.
the IGHV mutated, yes, if you give FCR, there is nothing wrong, correct. For the P53 mutated, again clear that it is yes, you can't give chemoimmunotherapy.
How many venetoclax have you given? If you ask me, also 0. So for the mutated, what do you do?
It's very well tolerated. If you are saying FCR, there has to be full FCR.
Yeah.
Not the compromised FCR. And that's difficult in India. You will lose some patients in the FCR.
So I think we need to conclude. So thank you very much for a very interactive discussion. I think a lot more data is coming up. Today we need to individualize therapy based on patient-related factors, cost and several other kind of comorbidities and other factors. So I think with that I'll conclude. Thank you so much. Dinesh, final takeaway for everyone.
सबको मेरे पास भेजना है So the simple answer is कि सबको मेरे पास भेजना है. The first one, Dara, if you are using a Dara upfront, you have to be careful with the infections because we lost our 1 or 2 patients with the Dara. The patient in the first 2 months is immunocompromised. So your pneumonia and sepsis is the important part. So if you are using a Dara upfront, be careful with the IgG level, check the IgG levels, give IVIG and monitor closely during the first 2 months for the infection. So that's the most important thing. The second is the CLL, we don't have venetoclax, so the answer is easy, we use acalabrutinib. So I'm using acalabrutinib for everyone, well tolerated. Still you have some cardiac, so you accept the people who have a cardiac high risk, you can use we are using without anti-CD20. So there is enough data to suggest you don't need anti-CD20 with acalabrutinib alone. So it's easier, except when someone has a high risk for cardiac, you can use a BR. No one is using FCR. If you are using FCR, you have to use a full dose. No, there's no data with the compromised FCR. So I think and acalabrutinib is well tolerated. When we get a venetoclax, yes, we should follow this. You need to have a reliable MRD data. So if you are going with this trial, we need to have a reliable MRD data. That's my practice which I can explain. Thank you.